Hi, I am Dr. Harris, and this is my examination of the foot and ankle joint. Great, if you could stand up for me, please. Just stand there for me, please. Hi there, my name is Dr. Harris. Today I'm going to examine your foot and ankle joints. So first of all, I'm going to start off by getting you to walk for me, and I'm going to have a look at the ankle joints, get you to do some movements, and a few other things as well. Is that all right?
Yes.
Excellent. Before we start, have you got any pain anywhere?
No.
No? Okay, brilliant. So first of all, I'm going to get the patient to start off by walking so I can inspect their gait. I always wash my hands before I examine the patient as well. So if I can get you to start where you are and walk towards the bookcase and back for me just normally. So I'm inspecting the patient's gait, looking for any abnormalities in the gait, any antalgia. That's great. And then when you walk there, if you could walk on your toes and walk back on your heels. Again, functionally looking that the patient has good neurovascular supply to the legs. There's no abnormality in the patient's gait, and they've got good function as well. I'm going to start off by inspecting the patient. So looking at the patient's legs and feet. So working down anteriorly, they've got good alignment, there's no obvious deformity, there's no obvious muscle wasting to either leg. Working down onto the ankle joint, there appears to be no obvious swelling or redness to the joints or deformity. Moving on to the feet, however, I can see that there's evidence of pes plantis on both sides. And actually looking in the patient's footwear, I can see that he wears orthotics to assist with this. Again, looking further down and looking at the patient's toes, there's no obvious alignment deformities or hammer toes. And if you can turn around for me, please. Again, looking at the back, again for any muscle wasting, looking for any obvious scars as well, which I did anteriorly as well, and again looking at the alignment of the ankle joints. If I can get you to stand on your tiptoes for me whilst you're in that position. So functionally, that's great, thank you. The Achilles tendon is working appropriately, and the calf muscles are nice and strong. If I can get you to have a seat in the chair. I'm going to continue my inspection by just looking at the sole of the patient's feet. I'm just going to move to this side. So I'll just, for the purposes of the video, I'd always examine the patient's right and left foot, but I'll just examine the patient's right foot at the moment. I'm going to get you to lift up your foot for me. I'm just inspecting the sole of the patient's foot. Again, looking for any obvious scars and looking for any calluses or redness to the skin. Again, looking between the patient's toes for any skin complaints, and just a closer inspection of the foot in general. That's fine. So I've started by inspecting and watching the patient walk, so I'm now going to move on to palpating the joints. So again, I'll just focus on the right foot and ankle today. So I'm going to start by palpating down the tibia. For any pain, is there any pain there at all? And over the anterior ankle joint. And then I'm going to move around and palpate over the medial malleolus for any pain or tenderness, and over the lateral malleolus. Is that all right? I'm also going to feel around for the ligaments attached to the lateral side, any soft tissue problems or pain. No?
No.
I'm going to move around posteriorly and palpate up the Achilles tendon. There's no obvious gaps there at all. And then I'm also going to palpate the calcaneum. And then I'm going to move on, palpating along the metatarsals, and palpate over the forefoot, over the navicular. And then whilst I'm over the forefoot, I'm going to squeeze as well. Is there any pain there?
No.
Might be evident if there's any pain in the metatarsals or any Morton's neuroma. I'm also going to palpate down the lateral side and moving on to the toes. I'm then going to palpate over the joints of the digits, so the metatarsal phalangeal joints as well as the interphalangeal joints. Any pain there at all? So on palpating the foot, there's no evidence of any pain on palpation or any obvious deformities. All ligaments appear intact as well. Now we're going to move on to getting you to do some movement, if that's all right. So firstly, I'd ask the patient to do active movements, and then I would passively help the patient move their foot as well. So just get you to do some few movements with your foot. If you point your foot down to the floor, and then up to the ceiling, and then move your foot inwards and outwards, and then circle the ankle joint. That's great. So I'm just going to help you with those movements. Alright, so move your foot up to the ceiling, down to the floor, moving your foot inwards and outwards. And then I'm going to stabilise the ankle joint and just move the forefoot for rotation. And then moving on to the toes. Can you claw roll your toes for me, please? And then straighten them all out. And then I'm going to move and relax. I'm going to move them for you. So just moving to assess full range of movement and any pain as well. That's fine. So I've now moved the joints within the ankle and the foot. So I'm going to move on to special tests. There's two special tests that I'd like to do. The first one is looking at any instability within the anterior ankle joint. By that I'm going to stabilise the tibia, and then pulling forward on the foot I'm going to assess to see if there's any excessive anterior movement of the foot against the ankle joint. On this patient there is none, and there's no pain present as well either. No, good. I'd always assess both joints for comparison, as some people may have a natural laxity to their ankle joints. It's always good to compare both sides. And then I'm going to ask the patient to stand up. I'm going to assess the function of their Achilles tendon using the Simmons test. So again, I will just assess, if you turn around for me, the left side because it's closer. If I just get you to bend your knee onto the chair for me, using this leg. So putting your knee onto the chair, that's it. And then what I'm going to do is just squeeze your calf muscle. So I'm squeezing the calf muscle, assessing the integrity of the Achilles tendon, and there appears to be intact and no problems with the Achilles tendon as the foot is moving appropriately. That's great, you can have a seat now, thank you. To complete my examination of the foot and ankle, I'd want to perform a full neurovascular exam as well. So to do that, I'm just going to start assessing the patient's neurological status of their legs. So first of all, if you just relax your legs for me, I'm just going to assess tone and then power. So if you keep this knee bent and lift it up to the ceiling for me, good. Keep your knee bent and push it down into the floor, good. Kick out with this leg against my hand, pull backwards, good, relax, bring your toes up to the ceiling, keep it there and push down like a car pedal, good, bring your big toe up and push down with your big toe, lovely, and obviously assess both sides. So I've done power, tone, and I'm going to move on to sensation. Can you feel me here, 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 and here. And coordination, I'd like to assess this by if you place your heel on your knee and drag it down your shin backwards and forwards, please. Brilliant, and swap sides. Lovely, that's fine. And finally, I would assess reflexes as well. Unfortunately, I don't have the tension hammer, but I would assess the knee reflex, the ankle reflex, and a plantar response as well. Moving on to vascular supply, whilst palpating the legs earlier, I assessed their warmth as well, but again I can assess now to make sure that the toes and feet feel nice and warm appropriately. I assess capillary refill by pressing for 5 seconds and then seeing the capillary refill time, which should be less than 2 seconds. And then I move on to palpating the pulses. So I'd palpate for the posterior tibial pulse behind the medial malleolus on both feet. It's always better to assess proximal pulses first, because if these are present, then it's more than likely that the distal pulses will be present as well. If I was unable to feel these, then I would move on to feeling for dorsalis pedis on the top of the foot. If I was unable to feel the pulses, I could use a handheld Doppler machine to help me find them. So to summarise, I've assessed the patient's gait, I've inspected their feet for any abnormalities as well as the soles of the feet. I've got the patient to move the ankle joints, and both actively and passively, and I've assessed for any anterior instability in the ankle as well as the integrity of the Achilles tendon. To finish my exam, I assessed the neurovascular supply of the legs, and for any joint exam it would always be appropriate to examine the surrounding joints, and therefore for this exam I would like to examine the knee joints as well, and this completes my exam.